Hi, we're here today with this podcast where we've got the guest for today, and the guest for today is the English physiotherapist and PhD Roger Kerry from Nottingham. Roger, I think you're better to introducing yourself than I am. So, could you introduce the listeners to who Roger Kerry is? Besides, he's a physiotherapist that likes playing music.
Well, it's just about what you said. My name's Roger Kerry. I'm from Nottingham in the UK. And I'm a physiotherapist who likes to play music. And I work for the University of Nottingham predominantly, and I've been around for a while. And yeah, I guess we've got to talk about some of the things that I'm interested in, really. So see how it goes.
Yeah, see how it goes. So one of the things we would like to discuss or talk about today, Roger, was the use of manual therapy and hands-on in physiotherapy, which I believe has been to quite some debate during the last couple of years. And I also think that it's one of the things that when we start our undergrad education as PT, we're very interested in what we can do with our hands. So the whole debate about hands-on or hands-off, it seems to be pretty like dichotomous, meaning you're either on one side of the pond or you're at the other side of the pond. Is that a correct interpretation of how the talk goes, especially on social media?
Yeah, no, I suppose that's where the problem is. People see this as a either or thing, a black and white thing, and I suppose in some ways that's good because it forces some discussion. It forces you to really make the case for one of the extremes, and that can be quite healthy because you have to think a bit deeply about the problem. But the unhealthy side to that is the bias in that, and you just interpret all the data because you've already made your stance of where you are. So we just need a more sensible discussion somewhere in the middle. And you just said this has been going on for a couple of years, but it's been going on for decades, really, hasn't it? This idea of what we do with our hands and whether that's a good or bad things, and then going through phases of very, very detailed use of our hands in different models of manual therapy and all things like that. So it's been an interest when you look back on the whole thing. It's been very interesting. But the difference now is, of course, we have more and more empirical data to feed into that conversation. And as we've just said, that can serve a really healthy purpose, or it can be interpreted into whatever people want it to be, really. So I think the position I'm at now as an educator and a therapist as well, and as a sort of somebody who likes to think about problems as well, is with limited resources that we have and more expensive cost to healthcare, we do have to make some decisions about what we do and what's the best thing to do. Yeah. So I think it's a good time to have this discussion again for the 7,000th time in the last 50 years.
I think some of us are worried that the hands-on and especially the theories behind the different methods, because they don't seem rational based on the literature we have. That some of us are worried that we would like be put in boxes as those that are doing unrational, non-evidence-based things. Is that a fair position to have, to be afraid of being put in that box and compared to like those you think are not doing it right or based on a wrong principle? Because what's manual therapy are really doing? That was a whole shit of questions in one.
Yeah, I think, to be probably, I don't know if we should be afraid, but I think we should, wherever you are, whatever box you're in and whatever camp you're in, I think it's time, as always, to be questioning ourselves about, okay, what is the rationale for behaving like this and thinking like this? What is the evidence that underpins that? And we can talk about evidence in good time, I guess, but a lot of this is to do with multiple sources of evidence, and let's bring everything together and see what we can make of it. But it's always healthy to say, okay, what have I been doing for the last 5 or 10 years? what's the basis of that? Is it the best thing to continue doing? Are there alternatives I can get? And within all that, there's lots of questions as well, because like you've just sort of implicitly stated, Brian, there is something about fear and really professional identity, you
Yeah.
know, at whatever level you want to look at that. I mean, it's a deep sort of sociological, philosophical level. There's something about the history of physiotherapy and as being defined, you know, the characteristic difference between us and say nursing or medics is the fact that we're allowed into people's personal spaces much more easy, and we use this thing as touch as part of the therapy. And I don't think we can dismiss that. I don't think we could just ever say stop touching people, maybe for a COVID bubble we will be doing that, but at some time again I think touch will re-enter our profession, but then it's going to be a discussion about what is the nature and purpose of that touch, and in what form should it take. And I think there's a lot of things to be said about that, and I've got some opinions, and myself and a few colleagues in the UK are slowly preparing a groundbreaking manuscript on this. So I think there's some thoughts on that.
So could you reveal some of the key things in that manuscript, or would that be like, it would be uninteresting then for an editor?
No, not at all. I think, I mean, the thing is there's the amazing thing about it is there is nothing amazing about it. It boils down to common sense and just a sound, rational interpretation of the science we've got before us. I mean, we're interested in providing. I mean, it's one thing saying things like, "Oh, you shouldn't be doing that," or "You don't need to be doing that." But you really need to offer something in its place. If you're prepared to sort of take something away, then you could leave that space empty. But it's healthy, I think, to sort of say, but actually we could be doing something like this. And I think the thing is with manual I mean, this is before we started recording, Brian, as you know, you mentioned a paper from 2 or 3 years ago where sort of done that straw man thing and looked at the arguments, and but I genuinely wanted to bring the evidence together, and no matter how I interpreted the evidence, I don't think we could at this point in time say there is enough evidence to discontinue the use of what we call manual therapy, because there's trial level evidence, there's systematic reviews, it's embedded in guidelines, and even with that alone, never mind the sort of rationale and theory behind it, we haven't refuted scientifically the hypothesis that manual therapy is ineffective. So I think we need to find a new structure and a new framework of which to work in. And for us, and I'm speaking on behalf of the people I've been talking to about this, which is a couple of people at Nottingham, Vaz Georgiopoulos, Ed Lee, who's a colleague of mine, but also Adam Meekins, we've been having this conversation with us as well, because I think we need all sides of the argument bringing in. And I think a new framework of practice is fairly easy to establish, and there's lots of things we can get rid of. And again, one of the reasons we're trying to write this down and get it out in the open is to have criticism of it. And I think one thing people would be critical about is our statements about the lack of need for what we might call specificity and high levels of training in particular ways of doing stuff with our hands.
Yeah.
and maybe we can have a model where we could still do the thing that's effective about manual therapy, as shown in trials and stuff, but without the stuff that's not necessary.
So doing the manual thing without necessarily being on the lateral border of the L5 facet.
That sort of thing.
Yeah.
That sort of thing.
Because putting hands on people as a general thing has some effects. That's basically what we're going at. So it's not the specific technique. That's what I'm hearing you're saying.
Yeah.
But
A long-winded way of saying that. Yeah.
Yeah, but I guess the literature has told us that it doesn't have to be that specific. So I guess it's your premises must be based on stuff like that.
Yeah, or redefining what we mean by specific. Like you say, I think gone are the days when we talk about things like your example there being, if we want to do a grade 3+, it's just, this much more pressure than a grade 3, all that business. So I think if you look at the history again, we started off with this caring, a touch that was very caring, non-specific, but allowed some sort of connectivity with a patient, and facilitated movement, and learning a lot from neurology and things. The way a good neuro rehab physio would help a movement with a patient. And then we went through the late 60s, 70s, 80s, 90s, this period where all the different branches of manual therapy formed, and people became sort of obsessed with detail and technique, and started to concentrate on the things that probably don't really matter. Yeah. And in doing so, forgot about some of the things that do matter. And then a sort of middle ground in between, where some of what some people might call the theatricals of the detail, of the performance of the very, very skilled technique, actually do form part of the therapeutic response, but not in the way we thought they were doing. So it's making sense of all that, and then thinking okay, what are we left with then? In that, and how can we do that? And importantly for us as educators, what does that mean in terms of the training of new people coming into the profession? How do we do that?
Yeah, because what we're trying to do where I'm teaching is the fact that we used to be like 5 or 6 years ago, and further back in time, we were pretty concept specific. Where now we I think we're applying more general manual techniques, but that seems to actually to frustrate the students. Because they think, and that's another thing, Roger, because if the students look on social media or look at guidelines, it's not very cookbook, it's not very direct, and it shouldn't be, because we want them to use their clinical reasoning. But within clinical reasoning is also the aspect of some kind of clinical expertise, or not clinical expertise, but clinical examples. So I think it's very difficult for an undergrad to sometimes just feel relaxed when we're teaching on specific techniques.
And this is the problem. And I'm amazed, and I've been amazed particularly recently, over the last 2 or 3 years, about the perceptions that new entrants into the programs have of physiotherapy, and even an 18 and 19-year-old in 2019 would have a certain perception of what a physiotherapist is, and part of that perception was this ability to be very, very skilled with your hands and do this very, very detailed sort of manipulative technique that must be taken years to learn, and they want to learn that. And I'm not sure where those perceptions come from in this generation. It astounds me. So over the last 2 years specifically, we've been doing a lot of work with the first years. And again, like I say, it's not very successful to say, oh, we don't do that anymore. That's not the stuff we do.
That doesn't work.
That doesn't work, because like you say, that just frustrates them and disillusions them, and disempowers them then. And that's the last thing you want. But if we can say, right, yeah, we're going to be really good therapists who are going to really help people engage back in society, and one of those things we can do that is we can use our hands, but here's a structure that we're going to use. And basically we've got a simple sort of triangle that says, as long as you're safe, as long as everybody's comfortable and knows what to expect, and as long as you're efficient with your movement and with the patient's movement, if you work within with that, you can deliver all the therapeutic value of the hands-on stuff, and you still need to be very skilled, you still need to be very, very careful, and you still need to know how to not kill anybody and things like that.
Do no harm, please, man.
Yeah, exactly. And care for somebody, you use your hands to care and offer that additional therapeutic layer on top of all the other richer stuff that you'll be doing as a therapist as well. And I think if you start to present things like that, you do start to get some buy-in over time.
Yeah. So if you and I can agree on the fact that we might not have, or at least I said it out loud, you said it was implicit, I thought it was pretty direct, that the specific technique might not matter, or probably doesn't matter. How that? Because some of these techniques, or almost all of them, are built on a rationale that says you're either elongating things, you're making it relax, or you're pushing it, or stuff like that. So what's the explanatory model? As I mean, to why does it actually work? Even though we can probably disagree on how much it works, and the effect sizes are not that big.
I think the only explanation we've got from a biological point of view, first of all, is a neurological one. We've got fairly consistent data that says you've got some sort of neurology happening with descending pain inhibition and certain things peripherally as well. That's that's the extent we can go in terms of biological phenomena. But that might be enough. The fact that you are getting a neuromodulation might be enough for what you need. Now, of course, the argument against that is, well, you can get that same sort of neuromodulation from other non-hands-on therapeutic techniques. So then the discussion comes behind to, okay, so then what is the value of it? So if you've got two interventions, one hands-on and one hands-off, and they both offer the same neuromodulation, what is there any additional benefit from having a hands-on? And I think that's when we can start to look at the psychological and social aspects as well, and start to frame any hands-on process in terms of something more caring and tools to facilitate communication, and but also to facilitate movement on a neurological basis as well. Like a neurophysio, so nothing not facilitating movement in terms of we're loosening a joint, or we're releasing tissue, or releasing trigger points. Or it's hard to say some of these things without laughing at some time.
You're okay to laugh. Very okay. Just give it a go.
So we can facilitate movement with our hands, and that's manual therapy. I think we need to redefine what we mean by manual therapy, and redefine what we mean by being specific. So I'm not bothered about trying too hard to make the case for maintaining hands-on, but I think there's enough biopsychosocial arguments to sort of say, well, look, if we reframe what we're doing, we can see how people will connect with us better, will communicate with us better, and therefore we can help them on their journey towards wherever they want to be going, without the need to rely on that particular hands-on thing.
So again, it's not black and white as we want to say. No. And I think when you say the biopsychosocial thing, I think my issue is the fact that if we look at psychology and we look at maintenance care, I would probably, and I'm probably biased because I'm not fond of maintenance care. But I would say that if like telling people they need to come in every third month or even more often than that, I would say that we're having a negative effect on the psychological and probably also the social domain. But to be honest, I'm not that deep down in the literature on that. So it's probably more an assumption. And I think that's what's like saying, that's what sometimes make me say it doesn't do as much good as those people that are doing the maintenance care are doing. I don't know if I'm being fair now, but that's my feeling about it, I guess.
No, I think you're being fair. I think that's absolutely right. And this is about that ability of a clinician to understand what sort of patients and what patient groups are more likely to benefit and which ones are more likely to be caused harm in a biopsychosocial sense. Not that we do have that much data at all on the harmful effects of manual therapy. So it's probably better to keep the conversation towards levels of effectiveness. And I know it's tempting to get drawn into that conversation about, well, the things we say and the things we do cause harm. But I'm prepared to have that conversation when there's good data to support that. But if we talk about whether it's worth doing because of the effect size you're getting, then you're absolutely right. There are I think the majority of people we see probably can get away without that sort of level of therapeutic human touch. But there might be times when we do need to facilitate somebody's therapeutic alliance with the use of hands and hands-on interventions. I'd be happier as well if we started to redefine some of these words as well, like to become more human-centered and person-centered. Like interventions is quite a biomedical sort of term, but something, and if we can develop our skills better in communication and recognition of the needs of people as humans and adjust things like that. So your example of maintenance care is one which what on earth, that is crazy.
Yeah, because the data is pretty bad on it as well.
yeah.
So that also boils it a bit down now to like, do we have anything that tells us which patients are gonna benefit from manual therapy? I mean, we know that expectations seems to matter. No matter what thing we're throwing at people, if they expect it and they're giving it, this seems to have some effect, right?
Yeah.
And I also heard Chad Cook talk about those being pain adaptive, meaning those that if we put our hands on them and they have a fairly good response, we can say that either if it's actually our hands or this one is for you, Ben Cormack, if they have a directional preference. we know they have a good prognosis. So are those that are being pain adaptive, are those the people we should mainly use manual therapy on?
I think the group that we should use manual therapy on are probably a subgroup of all those people who are pain adaptive. And again, that our skill would be, the skill actually isn't in the application of the hands-on. The skill is in the recognition of who would more likely benefit from that. And I think the data takes us so far on that, and in years to come, we'll add to that. And we might have better clinical prediction rules to help us as well, although the problems within that as well. But using the science alone to direct us to who would benefit and who not is obviously a healthy way to think, but it's so far that doesn't clear the waters completely, because there's still a lot of unknowns in that. And I think within those on loans, it's still probably better to err on the side of caution. And if there's other ways to help people engage, move better, engage back in society without using hands, then go for that. And the hands-on stuff is the selective things we would do if we needed to reinforce that therapeutic alliance, rather than the first choice of treatment. And I think even on some clear-cut things like the clinical prediction rules for cervical and lumbar manipulation, pain this far down the leg, this side of the body, blah blah blah.
Less than 16 days.
Yeah. We need more skill than just to read a clinical prediction rule and apply that to a patient, because patients are more complex than a clinical prediction rule would.
So if I interpret what you're saying right, we need to be better at human beings to like more or less predict who would need the add-on as our hands.
Yeah, and that's part of our clinical reasoning and communication thing, which myself, you, like-minded people, we've always been proponents of anyway. We don't think, right, a good therapist is somebody who can do really, really good grade 3 plus on L4, and then the other things are a bonus. We know that a good therapist is somebody who connects, communicates, ensures and facilitates somebody to feel comfortable and ready to engage in an equal dialogue about their story and develop from there, and then anything else that are the sort of add-ons. And good clinicians have always been like that. It's just that, and I'm absolutely sure, and the people I've spoken to and the things I've read about the old guard, the Jeff Maitlands and Freddie Coltonborns and everything, and Greg Greaves, I think we've looked back on those and think they were really good because they knew how to do grade 3 plus on the transverse process. But no, they were good clinicians because they understood humans, and they were excellent communicators, and they listened and used those other things add on. But then we tried to model what they did, but take it from the manual therapy side and forget that it was not that made them the great clinicians.
Which comes back to the thing we talked about when they come in as first years. They come in 18, 19 years of age, and they have this view of our... to a good technique.
I just missed some of your sound then, Brian.
Okay.
I think you made a critical point in the...
Can you hear me now? You muted me, did you? No, what I'm saying is that based on what you said, that we boiled the good clinician down. We boiled him down to a manual technique. So maybe you and I in our profession is at the point where we actually created the look that the outside has on us, which explains why the 18 or 19 or 20 years old first year has the thing they want to be good with the hands.
Yeah. And that's easy. So that's the easy option as well, isn't it? To take that bit, because you can see it and you can be wowed by it and go, oh wow, look at the way they do this and they do that. Whereas empathy and communication, then they're not so visible things. So they're not going to hit an 18-year-old in the face and go, I just want to be as good at providing empathy as that person. It's much easier to see that. And then we've got our allies as well to think about, the chiropractors and the osteopaths, who are very visual people to make a judgment on whether they're good or not. You can see them, and if they can do this and do that, and then we think, well, that means they're really good. So we're falling down these rabbit holes and dead ends all the time, and I've done through history.
So we need to be more confident in not being able to be certain. I think we need to be confident into uncertainty.
Yeah, and as soon as we can get to that point, then the great, and Greg Grease said that years ago. He made a statement about that. The good clinician is somebody when they realise. This is paraphrasing him. I can't remember the exact quote, but when you've got that ability to be comfortable in uncertainty and the greyness. He had a wonderful statement. I can't remember what it was, but yeah, and these are the sort of skills we need to be teaching, and that's a challenge for the educator, because no student wants to learn about uncertainty, because they come into programs, particularly vocational programs, to become skilled and confident and certain about what they're doing. So that presents a great challenge.
And the other rabbit hole of that is that when we are testing them, we need to avoid testing those skills, right?
Yeah. Gosh, there's a minefield as well.
Yeah, we're not talking about that today.
Yeah.
We've got a sample in 3 weeks. I've got it planned already. You're not changing my mind. Let's keep it mechanistic, okay? Can we?
Right.
So if we bit back to the neuromodulation thing, I read, I think it was Adrian Lowe, where he's situated, they did a pilot study on regular lumbar PAs on 2 patient group. Are you aware of that study? Where one study they tried to engage people more actively, telling them they were remapping the sensory cortex, and the other group was told that if we what we're doing now is we're putting your joint back in alignment. Do you think that's the way we need to use our because we know the neuroscience and the plasticity and stuff that way? Could that be some of the ways of applying manual therapy more effective, or are we just doing the same thing? We're just putting words on now instead of the specific technique. We're actually just applying some different things, neuroscience, to the same thing, so making it an art again somehow.
Yeah, I think there's two things there. One is the idea of being honest as possible, which is most often necessary in terms of our communication. And
Roger, can you repeat that? You fell out.
Oh, sorry. I just said the answer to everything, and I forgot what it is now.
Late.
I would just say, something like that. We have to think about what is it you're saying, and how truthful and honest is what we're saying. And the other thing is what we're saying enhancing that non-specific placebo effect, which is something we should be doing. The skilled clinicians should be able to enhance that effect, and using that explanation can do that, but it's got to be an honest explanation about what we know from the totality of science. So if there was a similar experiment set up and you made 2 fabricated explanations up that were nonsense, but one happened to perform better than the other, then that doesn't really mean you should give somebody that explanation because it enhances the placebo. It's got to be a truthful explanation from what we know from neurology, from science, whatever the explanation is, and it will change over time. And it's got to fit in with somebody's cognitive capacity as well. And we shouldn't just throw explanations out at people and expect them to understand. It's working with somebody to get an idea of what they want to understand and how much that is going to help them.
So it's still going back to listening.
Exactly. Yeah.
I think Joletta Belton said it was like, what she called them, power tools.
Yeah.
So we start. I had this premise of today. I want to talk manual therapy with you, but somehow you got me over to the other end of the spectrum. Now we're talking about this again. It's non-specific.
But you can't remove the two, because what we do with our hands forms part of that therapeutic package if we do anything at all with them. So I'm never going to talk for more than 30 seconds about the specifics of manual therapy.
It's because it needs more trials, the specific things. We know that, both of us.
Absolutely. Just more RCTs. That'll help.
So now you said the word, and I hope you're okay with talking about that. It's not. I'm not throwing a big surprise at you because I know you're confident in this. Small effect sizes, RCTs. So from a very simple perspective, I, there's something in me that still says it should matter what we do to our patient. And the reason why there's only small effect sizes and everything seems to matter just a little, is that because an RCT within physiotherapy is the wrong way of doing trials? Because it comes from the medical things where we swallow the pill and we swallow the placebo pill. But there's so much theatrical setup about going to PTs. Oh, sorry, that was a bad question, like 7:45.
I'm trying to get the answer right here, because it's not a bad research approach to answer a specific question, but it's how relevant that question is to our world. I think we have misframed randomized controlled trials since the 90s in physiotherapy, based on the medical model, and perhaps thought, well, actually, look, there's some amazing examples in medicine of how thousands of lives have been saved because of an RCT or because of a systematic review of RCTs, and that's very appealing. And then maybe we thought, well, we'll do some RCTs in physiotherapy. But for some of the reasons you've said, I don't think it's a methodology that should have been prioritized as much as it has been, at the cost of de-emphasizing other methodologies. So we've spoke before and written in papers about an idea of evidential totality, where in order to understand what's going on and the truth, then we need a range of scientific methods to help us with that, including work from qualitative research, laboratory studies, observational studies, randomized controlled trials. But there's not necessarily priority of one method over the other. It's when you start to, when all the findings of all those studies start to point in the right direction, then you're onto something. And if that ties in with clinical experience and observations as well, that's great. But let's say if lots of those methods said they were pointing in one direction, but then an RCT suddenly showed the opposite, what we do now is think, well, the RCT wins because it's a better method, because it's low risk of bias, and we've been taught about this evidential hierarchy. But I think that's wrong. I think it's that interpretation and modelling of it that's wrong, not the actual scientific approach itself, because it does answer a question. It answers a question about effectiveness of a particular sample size in a particular study compared to another sample size. It doesn't say any sample. It doesn't say anything other than that at all. And then all the complexities of what we do fall outside that. So we can position the results of an RCT in our world, but I think it's a mistake to let it drive everything we do.
Yeah. Oh, that was a very elaborated question. Thank you. You can take a breathing again.
What a ridiculous thing to ask me that question at this time of night.
I'm not here to be your favorite Danish physio. But okay, I owe you a beer on that one when you come to Denmark in March next year. Fair enough, Roger. Maybe two, actually, but I promised you there would be a bar, though.
Yeah, well, I'm looking forward to that.
Yeah. So, Roger, I think we covered some ground here, and there's one of the questions when I don't forget it, I like to answer more experienced clinicians about and lecturers about, is the fact that what would be our best, us that has a bit of experience, what would be the best advice, the thing for young physios to do, what to make not to make a living, that was wrong saying, to feel comfortable within physiotherapy and to be as good as clinician as we can be. We're not talking about be the best clinician, but what should we do to make us comfortable and be the best we can be of ourselves?
I think conversations with new young therapists and students is about getting them to think about the real problems of the world, the big problems of the world, and what role physiotherapy has within that. And the big problems of the world are changing dramatically and getting more and more complex. But I see young students become enthused about when they start to understand that you know a big world problem could be addressed by some of the things we do as physiotherapists if we do it in the right way, and then letting it unfold about working out what the right way is. And then if you do let that unfold, you realize that to solve the big problems of the world, like the chronicity of musculoskeletal conditions, the burden of cardiovascular disease, the mobility problems of living in very poor parts of the world, access to healthcare, the answers to those problems isn't in the ability to do a grade 3+ on the transverse process of L4. It's about being a compassionate, empathetic, listening human being who wants to engage people back into the life that they want to be. And we can have wonderful conversations with very young people about those things.
Yeah, they seem to be opinionated, so it should be possible to facilitate stuff like that. I think you're totally right about that. So I think we're about the end, Roger. Where can people find out more about you if they kind of found this interesting and they want to know more about Roger Kerry? I know you're on Spotify.
Gosh, yeah, yes, yeah. Well, you can look at the Quarantine songs on Spotify, and we're all on Twitter, aren't we? At Roger Kerry 1. We've got some exciting things coming ahead with podcasts and online provisions with my colleague Alan Taylor. So I would advise people to watch this space for that, and that may or may not be under the title of the clinical reasoning sessions coming your way. And yeah, just see you on Twitter.
Yeah. Okay. Well, thank you, Roger. It's been an absolute pleasure. I really enjoyed the conversation.
Thank you so much, Brian. Thanks so much for asking me to talk with you. It's been a pleasure.
Good.